Good day all. This talk will examine the structuralist approach to understanding how health and healthcare work, focusing particularly on the theory of structural functionalism. For structural functionalists, society consists of structures performing functions. So, the medical establishment is obviously a social structure which society has created to perform the function of providing healthcare. The main issues for structural functionalists are how people play their roles within this structure and how it fits in with society's other structures. The creator and leading figure of structural functionalism was American Talcott Parsons. So we shall begin by looking at his work, which was first published in the 1950s and which became widely accepted in North American sociology. When Parsons examined sickness, he was not so much concerned with its harmful physical effects as with its potentially harmful social effects. For Parsons, health consists of being able to play your social roles optimally. Sickness could make it impossible for people to play their social roles, which could lead to a breakdown in society. We saw this recently when COVID led to labor shortages and supply chain difficulties, which disrupted the economy. For Parsons, the human body is a biological machine or structure which sickness can cause to malfunction. It is the role of the healthcare system to treat the sickness so as to make the body functional once more, so that the individual can properly perform their social roles. Parsons was not so much concerned with what health and sickness mean to the individual as with what they mean to society. Indeed, for Parsons, in social terms, sickness is a form of deviance in that it disrupts the normal operation of society. Parsons argued that society must deal with the difficulties and disruptions caused by sickness. It does this by assigning sick persons a special role, which Parsons, with, for him, surprising brevity, called the sick role. For Parsons, society is made up of social structures, which are made up of social roles. Every person spends their whole life playing a variety of social roles. The sick role is unique in that it provides an exemption from all your other roles. If you're sick, then you don't have to go to work or fulfill any of your other normal responsibilities. On the other hand, you do now have the responsibility of making your time playing the sick role as short as possible by trying to get well so that you can go back to playing your other roles. Parsons put this in formal terms by defining the sick role in terms of two rights and two obligations. The rights are, first, the sick person is exempt from normal social roles, and second, the sick person is not responsible for his or her condition. The obligations are, first, the sick person should try to get well, and second, the sick person should seek technically competent help and cooperate with the physician. I would argue that all of these put together amount to telling the sick person, shut up and do as the doctor tells you. The two rights take away the authority of those who normally run the sick person's daily life, such as their boss and even themselves. The two obligations assign the doctor as the sick person's new supreme authority figure. Indeed, the sick person must commonly obtain a formal note from their doctor to get off work. In social terms, the doctor legitimates the sick person's assumption of the sick role. Parsons was well aware of the authoritarian nature of the sick role. He was one of the first sociologists to argue that the healthcare system does not just perform the function of healthcare, it also performs the function of social control. The sick are placed under the control of doctors and, more broadly, of the healthcare system. Parsons saw no problem with this, but his model, which unquestioningly assumes the competence and trustworthiness of all physicians, has been criticized as naive. Indeed, each of Parsons' assumptions about the sick role has been criticized. Firstly, the sick person's exemption from normal responsibilities is not so straightforward. Disputes may arise over just how sick a person is. For example, employers frequently ask their employees to come into work even though they say they're feeling sick. When this happens, is it an unfeeling boss or a malingering worker? Sometimes it's one, sometimes it's the other. Either way, the sick role is in practice created in a process of social negotiation. Even in the home, if mom gets sick, dad will temporarily take over some of her domestic responsibilities, but she usually still ends up doing some of the work. Parsons' second assumption, that the sick are not responsible for getting sick, has been increasingly criticized as individuals have become expected to take greater responsibility for their own health. In particular, health has been increasingly connected to a person's lifestyle. While some illnesses are still seen as being outside of a person's control and so not their responsibility, a growing number are attributed to poor lifestyle choices which the person is seen as being responsible for. For example, obesity and its related health problems are seen as the result of poor choices in diet and exercise. Lung cancer and other pulmonary illnesses are attributed to smoking. Sexually transmitted diseases are attributed to sexual promiscuity. And a host of health problems up to and including death have been attributed to doing illegal drugs. Increasingly, persons engaging in such activities are seen as being responsible for their own health problems. Some doctors in North America have even refused to treat persons with unhealthy lifestyles, effectively denying them the sick role. On top of this, there's the whole gray area of mental illness. Normally, a person is considered to be responsible for their actions. But to what extent is a mentally ill person responsible for their condition, their feelings, their thoughts, or their actions? Since we're still unsure of the causes of many forms of mental illness, we're also unsure how much responsibility to assign to the individual and how much to external factors. Mental illness breaks social conventions and so makes most people uncomfortable. The mentally ill may not follow society's norms. This makes them unpredictable and so potentially dangerous. While only a small minority of mentally ill persons are actually dangerous, their unpredictability causes many to shy away from them, leading to social rejection. This means that while they may not be technically considered responsible for their own problems, they are in practice treated as though they were. Mental illness also affects Parsons' third assumption, the sick person's obligation to get well. Mentally ill persons may not consider themselves to be mentally ill and may indeed be offended by the suggestion that they need professional help. In extreme cases, such persons may have to be committed. In other words, society may assign them to the sick role against their wishes. On the other hand, hypochondriacs have a mental illness which manifests as the belief that they have many physical illnesses, leading them to fulfill their obligation to get well by needlessly tying up the time of many doctors. Now, when Parsons wrote his theory in the 1950s, get well basically meant go to the doctor. And so both of his obligations, his third and fourth assumptions, were essentially the same. However, times have changed. One consequence of the growing social pressure for individuals to take more responsibility for their own health is that people have become more knowledgeable about their health and so less trusting of doctors' expertise. In particular, the internet has undermined doctors' authority, at least to some extent. Most people no longer blindly accept whatever their doctor says. They go on the internet and find out all they can about their ailment. Then they discuss treatment options with their doctor instead of just taking his or her initial recommendation. Growing information about medical malpractice has also undermined the public's trust in doctors. And as doctors' authority has declined, alternatives have grown. Millions of people now use various forms of complementary and alternative medicine, or CAM. While some forms of CAM have a scientific basis, others do not. So, are such practitioners technically competent help or not? Are CAM users really trying to get well or just avoiding their responsibility to go to a real doctor? What appeared straightforward to Parsons is now problematic. In the late 50s, well-known structural functionalist Robert Merton built on Parsons' work. Where Parsons examined sickness as a social role, Merton examined medical practice as a social role. Merton and others studied medical students and concluded that medical education is not just a process of memorizing facts and techniques. It's also a process of socialization into a new social role. Assuming the role of doctor does not just mean learning things. It also means learning a new way of thinking. Merton found that as the students learned more, they became more comfortable in the new role they were adopting and began to think of themselves as doctors, gradually redefining their self-image to fit into their new social role. But in order to do so, Merton found that they had to develop two distinctive mental abilities: emotional detachment and managing uncertainty. Emotional detachment is necessary because if doctors get too involved with the pain, suffering, and even sometimes death of their patients, then they'll just start crying and be unable to do their jobs. Doctors must learn to control their emotions, even in what would normally be considered very emotional circumstances. Managing uncertainty is necessary because doctors know that they don't know everything. Very often, they cannot be absolutely certain that they've made the right diagnosis or prescribed the right treatment. They could be wrong, and that could have serious consequences for the patient's health. Uncertainty is a part of life, but for doctors, it can be uncertainty about life and death decisions. But they cannot let uncertainty or anxiety paralyze them. They have to learn to live with it and do their jobs. In short, everyone has to learn how to play social roles like patient and doctor. And what needs to be learned is both intellectual and emotional. In the late 20th century, structural functionalists turned to the study of the social determinants of health. This is a very empirical and statistical approach. It's based on the premise that every individual's position in society determines their health. It isolates specific social variables and then attempts to determine their impact on health and healthcare utilization. I shall briefly now look at their findings on the main social determinants of health, which I shall present in alphabetical order: age, ethnicity, gender, income, and occupation. We begin with A for age. The most obvious correlation between health and age is that as we get older, our health gradually deteriorates until eventually we die. However, this is not the whole story. Each age bracket has its own health risks. I shall divide up these age brackets not by years but by life stages into infants, children, adults, and seniors. And I shall examine each in turn now. Historically, infants have had the highest mortality rate. This is because infants' bodies have not yet fully developed, so they're weak. In particular, they have a weak immune system, which leaves them vulnerable to disease. In early tribal societies, about 1 in 3 babies born did not live to see their first birthday. However, in the course of the 20th century, infant mortality rates dropped dramatically across the Western world. Today, in Canada, the infant mortality rate is less than 5 per 1,000 births, and in Iceland it is less than 1 per 1,000. This change, even more than people living longer, has been responsible for the statistical increase in life expectancy. However, problems like low birth weights mean that infant mortality remains higher and life expectancy remains lower for the poor, ethnic minorities, and third world countries. According to the World Health Organization, globally, every year over 4 million infants under the age of 1 die, and over 4 million more children under the age of 5 die. Most of these deaths take place in poor countries from diseases easily treatable in the West, such as diarrhea, dysentery, pneumonia, malaria, and so on. In the West, however, the decline in infant mortality has been balanced by a sharp decline in the birth rate, caused by the invention of effective birth control and the outlawing of child labor. Up to the mid-20th century, infants were the largest age bracket in the population. Today, they've been surpassed by the so-called boomer generation, and projections of Canada's future population estimate that soon there'll be a roughly equal number of people of any given age. Once they get beyond infancy, people become children. Children have their own health problems because they're completely dependent on adults, normally their parents. This means that any problems associated with their parents' social position are passed on to the children. Parents' poverty means that their children are more likely to experience inadequate shelter, malnutrition, disease, accidents, abuse, and other problems which can negatively impact their physical and mental health in adulthood. Young adults are the healthiest segment of the population. However, they too have their specific health problems. Women may have health issues surrounding pregnancy and childcare, while young men are more prone to risk-taking, which leads to death, injury, and illness through alcohol, drugs, multi-partner sex, traffic accidents, violence, and so on. And finally, as regards age, senior citizens are the fastest growing segment of the Western population. Average life expectancy in Canada has risen from about 68 in 1950 to about 83 today. We are going through what's been called the greying of the nation. The elderly generally suffer from several chronic illnesses, take a number of different medications for them, go to the doctor more frequently, and are more likely to be hospitalized than any other age bracket. However, in surveys, most seniors still report general satisfaction with their lives and their health. In particular, those who are able to maintain their independence and live in their own home feel a greater sense of control over their lives, which leads to better quality and length of life compared to those who must enter institutions and feel a corresponding loss of their sense of purpose in life. However, this is the age bracket which is most susceptible not just to physical ailments, but also to various forms of dementia, including Alzheimer's and Parkinson's, and so needs the most care. When life expectancy first began its consistent rise in the early 20th century, some people believed that this rise would continue indefinitely. However, this has already proven not to be the case. In Canada, the rate of increase has begun to slow, and in the US, it flattened out in the late 20th century and has actually declined slightly in the 21st century, currently standing at an average life expectancy of about 77. What this tells us is that improvements in nutrition, sanitation, and healthcare can allow more people to live out their natural lifespan, but they cannot increase that lifespan. The human body has a built-in expiry date of about 100. Far less than 1% of people live beyond that age, and I don't think this will ever change. Yes, we're seeing more people than ever before living into their 60s, 70s, 80s, even 90s. But 100 turns around the sun is about the maximum that our bodies are built to take. And I don't believe that modern medicine will ever change that. The next social determinant of health I shall look at is ethnicity. Ethnicity impacts on health primarily because ethnic minorities experience systemic racism. This particularly affects visible minorities in countries with a white majority. First of all, ethnic minorities are discriminated against in the workforce. leading to high rates of unemployment and low wages, which lead to poor living conditions and so poor health. Secondly, discrimination also exists in state-run services. White teachers are less supportive of children from ethnic minorities. White healthcare workers are more dismissive of the health concerns of patients from ethnic minorities. And the rise of the Black Lives Matter movement in the US has shown us that white police officers are all too ready to shoot young black men. In Canada, Indigenous people have experienced all of these forms of discrimination and more, leading them to have by far the poorest health of any ethnic group in Canada, including the highest rates of mental illness, self-harm, and suicide. Racism may also manifest itself in white supremacist organizations, such as the Ku Klux Klan, who have been responsible for hate crimes, including mass violence and even homicide, towards African Americans in the southern US. Such organizations also put out various forms of hate speech, which are offensive and emotionally harmful to their targeted ethnic group. On a more subtle and individual level, racists exhibit what have been termed microaggressions towards ethnic minorities, casual slurs and slights that have become so routine that they're not even consciously noticed, but which are internalized by their recipients and gradually wear them down, harming both their physical and mental health. Next, we shall look at health and gender. Men's and women's differing social situations and social roles have differing impacts on their health. The saying in modern medical circles is, "Women get sicker, but men die quicker." In more technical terms, women get more chronic ailments, men get more acute ailments. In other words, women get illnesses which don't kill them, but which drag on for years, whereas men feel fine until they drop dead, usually at a younger age than women. This is a consequence of the roles they play in society. Men generally do more dangerous, risky, stressful, and physically demanding jobs, so they're more likely to die suddenly due to accident, violence, or heart attack. Women's traditional roles in Western society are those of wife, mother, caregiver, and cook. These jobs lead to health problems like repetitive strain injuries such as carpal tunnel syndrome, joint pain, arthritis, and so on. Painful but non-fatal illnesses. Moreover, women are expected to put their families before themselves, working long hours and even going hungry to feed their husbands and children. In particular, when women are pregnant and breastfeeding, they are literally eating for two, and so need more food and also more rest. But in conditions of poverty, that may not be possible, so the woman's health suffers. Single women, especially single mothers, are more likely than single men to be poor, which again exposes them to more chronic illnesses. Women are also expected to provide health care for their families. While this may be as simple as putting a band-aid on a child's skinned knee, it may also involve long hours of back-breaking labor looking after elderly, bedridden relatives. The hidden home healthcare work of women takes its toll on their own health. As a result of all this, all over the world, women's health is significantly poorer than men's. And yet, despite this, women live longer than men. Globally, women's lifespan is about 8% longer than men's. In Canada, the average male lifespan is about 81. The average female lifespan is over 84. Next, we come to the single most important social determinant of health, which is income. There exists what's been called a social gradient in health, determined by income. As a rule, all over the world, the higher a person's income, the better their health. Wealth means health. Poverty means poor health. Moreover, the effects of differential income are cumulative over time. For the poor, more childhood illnesses lead to more adult illnesses. While for the wealthy, the benefits of a healthier environment and lifestyle just keep adding up. In subjective terms, poverty means stress, insecurity, anxiety, depression, and a feeling of failure and lack of control over one's own life, all of which contribute to poor health. Furthermore, poverty and poor health can become a vicious circle. Poverty leads to poor health, which makes it difficult to obtain steady employment, which leads to more poverty and more poor health. However, money can only improve health up to a point. The relationship between income and health is not a straight line, but a curve which gradually flattens out. Studies in Canada in the 2000s by Evan Morris and others found that once household income passed about $70,000 a year, further increases in income did not significantly improve health. On the other hand, those studies also found that health declines only gradually down to an income of about $30,000 a year, but then declines sharply with incomes of less than that. In other words, in Canada in the 2000s, about $30,000 a year was the minimum household income required to maintain good health. One policy implication of this is that a state-guaranteed household income of just $30,000 a year would not only do more than any other single measure to improve the health of the Canadian population, it would also pay for itself in reduced medical expenses. Welfare recipients currently have very poor health, which means they use far more medical and hospital resources than the average person. Lifting the poor out of poverty would also ease the strain on our overworked healthcare system. The final factor that I'm going to look at is occupation. Now, this is obviously connected to the previous factor in that occupation generally determines income. However, leaving income aside, different occupations also have different health risks, which I shall briefly examine. As a rule, manual labor has the highest health risks. In Canada, the highest rates of death and injury are found in occupations like manufacturing, construction, mining, chemical processing, transportation, and agriculture. In addition to workplace accidents, such jobs include potential exposure to dangerous agents, such as radiation, chemicals including pesticides and pharmaceuticals, infectious diseases, noise, poor lighting, poor ventilation, or excessive heat and cold. They may also include having to adopt unhealthy physical postures for long periods, and various kinds of occupational stress which can lead to psychological problems and even workplace violence. Office workers generally work in a healthier environment, have less physically demanding jobs, and suffer fewer acute health problems. However, over the long term, office work may lead to a variety of chronic health problems, such as carpal tunnel syndrome, lower back pain, eye strain, and even colon cancer. Sitting at a desk all day means that most office workers are not getting enough exercise, often have poor fitness and poor posture, obesity, joint pain, and heart disease. Working in a small enclosed space with other people also increases the transmission of infectious diseases like COVID, and can also lead to psychological problems like depression, claustrophobia, stress, and social anxiety. Another occupational issue which has arisen in recent years is the effect of shift work on health. About a quarter of employed Canadians now work shifts. But shift work disrupts the body's natural circadian rhythms, which has been found to lead to a host of health issues. Physically, shift work exacerbates asthma, diabetes, epilepsy, hypertension, cardiovascular disease, gastrointestinal disorders, and even multiple sclerosis, among other ailments. Psychologically, shift work may cause depression, fatigue, insomnia, the adoption of unhealthy habits like overeating and heavy drinking, and a withdrawal from normal socializing with family and friends, which can lead to a breakdown in social relationships, even marital relationships. That concludes what I have to say on the social determinants of health. The 5 factors I have examined are all objective and so are relatively easy to examine. There are also subjective determinants which have been examined, such as education, religion, culture, and even political beliefs. But their connection with health is more difficult to establish, so I shall leave them be. What matters most for structuralists is that there is a clear connection between a person's health and their social position. Each social position has its own typical pattern of health and sickness. Individuals can affect their own health up to a point with the lifestyle choices they make, but their health is primarily determined by their social position, and the health of society as a whole is primarily determined by the structure of society as a whole. That concludes what I have to say on the structuralist approach to health and healthcare. A transcript of this talk is available if you're interested. Good day.